Welcome to this high-yield review on elevated troponin without acute coronary syndrome. We will be building a clinical framework for understanding myocardial injury beyond coronary thrombosis. We will cover troponin biology, the critical distinction between myocardial infarction and injury, the categories of non-ACS elevation, special clinical scenarios, and the systematic clinical approach. We will end with high-yield exam pearls. Cardiac troponin is specific for myocardial injury, but not for coronary thrombosis. Any process that damages or stresses cardiomyocytes, ischemic, inflammatory, toxic, or mechanical, can release troponin. Elevation reflects injury, not necessarily infarction. The fourth universal definition of MI clearly separates myocardial infarction from myocardial injury. MI requires troponin elevation plus clinical evidence of acute ischemia. Injury is elevation without clinical evidence of ischemia. The presence or absence of ischemia is the key distinction. The cardiac troponin complex has three subunits: CTNC, CTNI, and CTNT. CTNI and CTNT have cardiac-specific isoforms. High-sensitivity assays allow detection of very low baseline levels, increasing positive results in non-ACS settings. Troponin doesn't only enter the bloodstream via cell death. The four mechanisms of release are necrosis, apoptosis due to hemodynamic stress, increased membrane permeability from inflammation, and normal cell turnover, detectable by high-sensitivity assays. Non-MI troponin elevation can be organized into three categories: supply-demand mismatch, or type 2 MI, non-ischemic myocardial injury, and chronic structural heart disease. Each has distinct mechanisms and management implications. Type 2 MI is a supply-demand mismatch without coronary thrombosis, common in the critically ill. Causes include tachyarrhythmias, hypotension or shock, severe anemia or hypoxia, and hypermetabolic states like sepsis or hypertensive crisis. Non-ischemic injury involves direct damage to cardiomyocytes. Examples include myocarditis and pericarditis, cardiac trauma, chemotherapy toxicity, and Takotsubo cardiomyopathy due to catecholamine stunning. Additional non-ischemic causes to consider are infiltrative diseases like amyloidosis, severe burns, and post-transplant vasculopathy. Always ask if there is a mechanism for direct myocardial damage. Chronic structural heart disease causes stable, chronically elevated troponin. A flat trend on serial measurements confirms chronicity. Examples include heart failure, left ventricular hypertrophy, chronic kidney disease, and stable coronary artery disease. We now turn to special clinical scenarios: troponin elevation in sepsis, atrial fibrillation, stroke, and pulmonary embolism. Each have distinct mechanisms and prognostic implications. Troponin elevation in sepsis and critical illness occurs in up to 85% of ICU patients. Mechanisms include cytokine injury, demand ischemia, and membrane permeability changes. Elevated troponin in sepsis is strongly associated with increased mortality. In atrial fibrillation, high troponin levels predict stroke and mortality, driven by demand ischemia. In acute stroke and SAH, elevation is due to catecholamine stunning. In pulmonary embolism, elevated troponin reflects right ventricular strain, correlating with mortality. Distinguishing acute from chronic elevation is crucial. Acute injury shows a dynamic rise and fall of at least 20%. Chronic injury is a stable elevation, common in conditions like CKD or heart failure. The dynamic trend dictates management. Our clinical approach uses a 5-step framework: evaluate hemodynamics, trend troponin, search alternatives, and assess ischemia. Remember the most critical principle: treat the underlying condition, not the troponin value. Any degree of troponin elevation is prognostically significant. It is associated with a 2 to 4-fold increase in mortality risk and independently predicts future heart failure, stroke, and MI. Even high normal values carry prognostic information. For high-yield exam pearls, remember that troponin elevation does not equal MI. Sepsis is a very common cause. Always trend troponin in CKD patients. And in PE, troponin reflects RV strain, not LV ischemia. Tachycardia alone can cause type 2 MI. Stroke-related troponin is due to a catecholamine surge. In heart failure, troponin level is a severity marker, guiding optimization of medical therapy. Your job is to figure out why the heart is injured. In summary, use a core framework. Identify the cause, trend the troponin to distinguish acute from chronic injury, treat the underlying condition, and respect the prognosis. Thank you for viewing this video.